The doors burst open, alarms blur with shouting, stretchers collide, and suddenly the emergency department is operating well over its capacity. Now, a mass casualty event has begun. Amid the surge, 2 patients arrive simultaneously. Patient A is wearing a tailored suit and articulates his symptoms perfectly. Patient B is unkempt, disoriented, and struggling to communicate. Medically speaking, their charts are identical. They have the exact same odds of short-term survival. But there is only 1 intensive care bed and 1 ventilator left in the building. To make that impossible choice, hospitals rely on triage. Originating on battlefields, these systems use colored tags to categorize patients strictly by medical urgency, intentionally stripping human emotion from the equation. The ideal standard is a purely objective algorithm. Doctors follow strict criteria meant to guarantee absolute fairness, evaluating the lungs, the heart, and the blood pressure, rather than the person. Yet, clinical data reveals a different reality. Even with strict protocols in place, these split-second life-or-death decisions are routinely hijacked by invisible prejudices. When humans are placed under extreme stress, the brain relies on heuristics, rapid, automatic mental shortcuts that bypass slow, analytical thinking. Faced with severe cognitive overload, a triage provider doesn't have time to consciously process every detail. Their brains fill in the gaps, instinctively pulling from deeply ingrained societal stereotypes regarding a patient's appearance, wealth, or background. This results in severe medical consequences. Studies consistently show that implicit bias leads providers to drastically underestimate the pain of patients of color, resulting in significant disparities in medication for identical symptoms. These providers are not operating out of conscious malice. They are highly trained professionals experiencing a universal biological glitch in human decision-making. When lives are on the line and time is short, the brain's own evolutionary survival mechanisms actively undermine our commitment to equal medical care. To bypass this human error, many hospitals turn to diagnostic scoring algorithms during disasters, trusting mathematical formulas to prioritize who gets treated first. But this creates a phenomenon known as false objectivity. The math appears neutral, but the formulas themselves contain embedded biases. This Washington State Department of Health document highlights the problem. Data supporting clinical severity scores derives from populations that exclude oppressed communities, skewing the math. Backed by citations, the state warns these formulas disguise long-standing societal prejudices as objective data. This chart surveys public opinion on allocating a scarce ventilator, showing a clear drop in willingness to treat disabled patients. The aggregated data reveals the public is 5.5 percentage points less likely to allocate a ventilator to them, despite identical short-term survival odds. An algorithmic protocol cannot protect vulnerable patients if the underlying math is built on a foundation of historical prejudice. We are left with an ethical paradox. A triage decision can perfectly execute hospital protocol, calculate the severity scores flawlessly, and still result in direct discrimination. This systemic shadow widens existing healthcare disparities. By the time a crisis hits, marginalized and unhoused groups are systematically denied life-saving resources. To combat this, health departments are beginning to implement a new operational standard for crisis care, the blind triage team. Instead of the treating physician making the call at the bedside, a separate committee of medical professionals makes the allocation decision. They review only objective, de-identified clinical data, completely blind to the patient's race, housing status, or physical appearance. Think back to patient A in the tailored suit, and patient B who was struggling to communicate. If the triage committee can only see their identical vital signs, we have to ask how the survival outcome changes. Achieving true fairness in a disaster requires acknowledging our biological flaws and engineering systems that actively block them out.